Thanks. So, the next speaker, Bynocs Dichoptic vision therapy. Can we replace patching? Dr. NISHEETA PATNAIK.
After that is Dr. Vibha. She's here.
You are not a ratified member, no? So
No,
this
she's
is not.
Dr. NISHEETA. No, she's not ratified. So, you will not be considered.
She is presenting what? Bynocs.
Bynocs.
Good afternoon, everybody. I'm Dr. NISHEETA PATNAIK, and I'm going to be presenting on Bynocs Dichoptic vision therapy. Can we replace patching? As we all know, amblyopia is one of the leading causes of unilateral vision loss in children, out of which 35 to 40% is attributed to anisometropia. Treatment options include our conventional patching, which we know is very easy to understand, is inexpensive, but we also know that it is very difficult to maintain that compliance in those children. Recently, we have come up with Dichoptic therapy, wherein it is a computer-based or a screen-based therapy, wherein we know that the compliance is very good because it keeps the children interactive, it keeps them occupied for the amount of time that they are playing the game, but there is that initial expense, and the studies that we have are not giving conclusive results. The aim of our study is to investigate the efficacy of the Dichoptic therapy versus patching in children with anisometric amblyopia based on best corrected visual acuity attained, binocular single vision for near and distance, and stereopsis gain. Methods and materials. Our study was a non-randomized, comparative, prospective study that was conducted between the months of April to June of 2021. We had 60 patients, out of which 30 was in each group, and the ages was between 7 to 13 years of age. The amblyopic eye vision was taken as logma 0.3 to 1 and or an inter-eye difference of 0.23. Exclusion criteria included eccentric fixations, high refractive errors of more than -6 or +4, prior Dichoptic therapies, any developmental or learning disabilities, prior intraocular surgeries, ocular comorbidities, and non-compliance or inability to follow. The Bynocs system is a home-based, cloud-based system. So each child or each family would have to have a laptop or a desktop that had a minimum size of 11 inches, Google Chrome as their web browsers, a scale or ruler for measurement and calibration, the anaglyph glasses that is provided by the product, either it's red, green or red, blue, and a working knowledge of how to set up Zoom, because they would coordinate with the Bynocs operators to change their calibrations. This is an image of their games that they would have. So what they would do is they would rebalance the contrast between the two eyes. So the better seeing eye would have minimum amount of contrast for them to be able to visualize the target, while the amblyopic eye would be put on maximum amount of contrast. So in these cases, like the blue car or the blue bowl on the right side would be their amblyopic eye, and they would have to navigate through the game to avoid the red cars or the red balls and catch the blue ones. So they would actively use their lesser seeing eye. In our results, we first went on with mean vision. We noted that mean vision improvement was better in Bynocs, where we saw that there was 1 logmar improvement, while in patching there was 0.5 logmar improvement. In case of BSV gain for near, we noted that about 75% of the children improved in the Bynocs group, while only 66 improved in the patching group. This reversed in the distance gain. BSV distance, we saw that there was 55% improvement in the patching group, while there was 41% improvement in the Bynocs group. Stereo gain was noted. So we saw around 20 patients in the patching group that had no stereopsis, and about 40% of them improved to having gross stereopsis. Similarly, in the Bynocs group, there was a less improvement. So there were 28 patients that had no stereopsis, and 17% of them improved to having gross stereopsis. We also did a median improvement in the amount of stereopsis that was seen. We noted that the Bynocs group showed a larger increase in the stereopsis, showing a median increase of 0.52, while there was 0.14 improvement in the patching group. There were various studies wherein they have compared patching with these Dichoptic therapies. The latest ones being by Roy et al. And Jost et al., wherein they compared the smartphone-based Dichoptic therapy versus patching. They noted that the vision had similar improvement between patching and the Dichoptic therapy, but Roy et al. Specifically noted that the near stereo improved in Dichoptic therapy. Jost et al. Also saw that vision improvement was similar in both groups. the limitations of our study is that it's a small sample size. We did not randomize these patients based on the fact that there is that initial expense. So not all patients can afford to have a computer or the system as such. We did not age match our controls. It was a short follow-up. So if we had a longer follow-up, we've seen that patching patients tend to have an improvement after 6 to 8 weeks. So these patients were only followed up for 1 month. So we did not give patching group enough time to gain that amount of vision or stereo. So that is one more thing. In conclusion, we have seen that based on the parameters, Bynocs did better in mean vision, BSV for near gain, and median stereopsis did better in Bynocs, but the BSV distance gain and the stereo gain as such, patching showed a little better improvement. So finally, coming back to the question of can we really replace patching, an old, age-old, tried and tested method. Bynocs, though requiring an initial investment, showed an improvement in vision improvement. Though it did not outdo patching in terms of BSV and stereo, it is a good alternative to occlusion therapy, especially in terms of compliance. Thank you. I have no financial disclosures.
So this was any patient who already had patching was taken up? Or?
No, ma'am. They
No.
did not have patching before. So if we had a new patient, we'll give them their glasses, call them back in 1 month, see their improvement. If it's stagnant, there's no improvement beyond a particular level, we offer them the Bynocs therapy. If they're willing to be included in the study and if they have all the requirements, then we take them. We have not given them patching. Age group was 7 to 13, sir.
7 to 13 is on the other side, it's higher age group.
Higher age group. Yes, sir.
So even the patching group also
Okay.
they were not treated before.
They were not treated before.
Short
Time.
follow-up.
Very
Age
short
group
follow-up.
is older.
Yes.
Age group is also,
Yes, sir.
But there is a short
you
of
had no
time.
conflict of interest with Bynocs fellows?
Oh, she's
Sorry,
not
sir.
included.
You had no conflict of interest
Okay.
or financial interest?
No.
Okay,
no,
okay.
sir. Right now we have, actually there's a second version that's come out now. We're the ongoing study is going, and we're not comparing with patching, but we're taking all possible amblyopia and trying to find out if there is an improvement. We are taking microtropia also. Ideally, it's very controversial. We're trying for microtropia. We're trying for patients who have undergone cataract surgery as well. And we are...
Okay.
Cheap. You also
Yes,
Thank-
look
sir.
at the
Yes,
cost.
yes, sir.
Thank you. For short of time, I think we will
Very good.